Dzień dobry. This is the first time that I visit a country where I am not in the capital city. So I think, as for one of the previous panelists said, Wrocław seems to be the best of Poland. I think, as a new visitor to Poland, being for the first time in Poland in Wrocław, I cannot concur more. So thank you so very much to the University of Lower Silesia for organizing this and for inviting me here. Thank you very much to the hospital for co-organizing, again for inviting. And very importantly, thank you to the Open Dialogue Institute for moving this forward with a lot of energy and trust and confidence and openness. And last but not least, thank you to Roberto Mezzina that put us in touch. I heard about what's happening in Wrocław from Roberto, who is a dear colleague and a friend and a partner, the power of networking in mental health. And I was very curious to come here to see what is happening, because apparently, as per Roberto, great things are happening, and I had a chance to have a taste of that during yesterday. I was introduced as the regional advisor for mental health in WHO Europe, and that means that I am the team leader for the mental health program of WHO Europe. Just a little bit of explanation. WHO Europe is a very large, it's an organization that is composed of 53 member states. So Europe for us is not simply European Union, but it goes beyond the European Union borders. It includes all the former Soviet Union countries, the Balkan countries, Central Europe, obviously. So it's 53 member states. Now, why I'm saying that is not to impress you with a number. It's rather to remind us all here of how diverse the WHO European region is. And in this diversity, there is so much to learn. So much to learn about successes, and so much to learn also about mistakes. And this brings me to the discussion today. Also, one of the esteemed speakers earlier today asked, is this a revolution or an evolution? You asked the question. And usually revolutions are domestic products. So if you decide it to be a revolution, it's your decision. But what we can do for you is share with you what didn't go well elsewhere and what you can avoid. You can avoid wasting your time and resources in things that we now know do not work. Another thing about myself is that I am myself a psychiatrist, and I have started my career working in a psychiatric hospital that had both acute wards but also a chronic long-stay ward. And I am a first-hand witness of what they call institutionalization effect. I have seen how an institution can reduce social skills of individuals that are living inside the institution for a long time, but can also produce an effect on staff that has worked in that kind of institution for years, if not decades. And this is only my experience, but it's an experience that is shared with other people that have worked in institutions like me, and that share the evidence that has been built along the years that the institutions are inefficient. They are too frequently inhumane. And if there is anyone here that would like to argue that on the basis of your experience there are no violations of human rights in the wards you work, I'm not going to challenge that, because you know better. But there is sufficient evidence worldwide, in Europe and elsewhere, to prove that a mental institution in its classic form is the best place where human rights violation can and will occur. A mental institution is typically understaffed And this is where, because of lack of resources, people are reduced to stay behind locked doors and are denied any other opportunity to maintain social skills, to maintain daily skills. And what we see as a reduction of personal functioning, some of us interpret as the effects of schizophrenia. Instead, most of the time, those are the effects of institutionalization. So not only they are inefficient and they are too frequently inhumane, but they were existing, they continue to consume the majority of mental health budgets. Even in the WHO European region, that is the richest region of Earth. We are far richer than the African region, than the Asian region, than the Americas region. We still do have, where we have institutions, they eat the budget. And then whoever among us wants to change things, and we go to the governments, to the ministries of health, to the national health insurance funds, and we ask for more budget for the innovative services that we want to develop, very often the answer is, oh, but we don't have budgets. And the reality is not that we don't have budgets, is that the budgets we have are used not in the adequate and appropriate way. But we'll talk about that in a while. So now, why is this huge deal about mental health? Even if we weren't mental health workers, that we are in this room, we would have heard by now a lot about mental health. Both COVID-19 and the war in Ukraine have brought mental health into an undeniable prominence. Everybody is now talking about mental health. It's like suddenly the public is becoming aware that everybody is vulnerable. All of us have, our mental health is vulnerable to challenges, is vulnerable to poor health, and so on. And it's like it's only now that the public is understanding that. Before COVID, before the war in Ukraine, in Europe, when we talked about mental health, the public imagined those people that are locked up in institutions or those people that cannot function in real life. Now, it's obvious that 1 in 4 of us here in this room will have, at a certain moment in our lifetime, will experience one or the other mental health condition. So what we see here, is it? Yes. So 1 in 8 people live with a mental disorder worldwide. Of those, we have a bit more than half are females and a bit less than half are males. 1 in 100 deaths in the world are due to suicide. It's a tremendous number that we don't talk about enough. Then we have that more than 50% of suicides happen before the age of 50, when people are still in the prime of their life, where people are either adolescents or young persons, or in their life when they care about families, when they are supposed to have a work life, and still more than half of suicides happen when people are still too young to die. 1 in 6 years lived with disability worldwide are attributable to mental disorders. And then the cost in dailies, in disability-adjusted lived years, is 190 and 129 millions. And mental ill health accounts for more than 5% of the global burden of disease. But then you don't hear about that too much. You hear about heart health, you hear about diabetes, you hear about obesity, you hear about infectious diseases, but then 5% of the global burden of disease, so 1 in every 20 people, the global burden of disease is due to mental ill health, and we don't have sufficient talking about. And what's also very important, that again, it's not talked enough, is that people with severe mental health conditions die 10 to 20 years earlier than the general population. And this is again not spoken, not talked about sufficiently enough. We don't think about how shorter life people with severe mental disorders have. We don't think of people with schizophrenia dying 10 to 20 years earlier than the rest of us here. Why? Because of the reasons we talk in a minute. So there are tremendous gaps in mental health. We have insufficient and inadequate responses. We have an information gap. For instance, in Europe, where you would think the best health information would be in the world, we still have only 74% of countries, of our member states, disaggregating data by age. And only 65% of them disaggregate data by sex. What does that mean? That means that 1 in 3 countries of WHO European region do not disaggregate data by sex, male or female. And you would think this is preposterous. You would think that at the 21st century, health information systems should be able to understand how many men and how many women are we taking care of. But still, 1 in 3 member states does not do that, is not able to do that. What are the reasons? They are very complex reasons, but the reality is that we, in total, have poor data. In terms of governance, implementation of mental health policies aligned with human rights instrument is low. Only 34% of our member states admit that their laws and their mental health plans fully aligned with international instruments such as the United Nations Convention for the Rights of Persons with Disabilities. We have a resource gap. In Europe, only 3.6% of general government health expenditure per capita goes to mental health. And that is a very important number if we know that some of the richest countries of our region, like France and Italy, spend much more in mental health than some of the countries that are at the poorest pole. So there are some countries who spend just a bit more than 1% of their total general government health expenditure. So the disbalance is very high. And last, we have a tremendous service gap, and in Europe, a lot of people with mental health conditions go untreated. The treatment gap is deeper if we go further east in the European region. But even in the rich Western Europe, the treatment gap is unacceptably high. So what are the key principles we base our work? One is that mental health is critically important for everyone, everywhere. It is integral to our general well-being. It's a basic right. Everybody has a right to mental health and well-being. And it's relevant to many sectors and stakeholders. Only today we have representatives of a university, which means that education sector is aware about the responsibility they have in producing newer generations of professionals that are adequately and appropriately trained. We have local governments here. That shows also the relevance of the awareness of local governments in supporting, as a stakeholder in supporting mental health. And mental health is important for connecting. Roberto is a connector, he's the networker by excellence. To function, we need mental well-being to function. To cope with adversity, we hear about climate change, we hear about COVID, the war in Ukraine is at our border, and no wonder we're anxious, we're in fear for the future of our children, for the future of the planet. So we need good mental health and well-being to be able to cope and also to thrive. our young people, teenagers, children, in order to thrive, they need to be surrounded and to benefit from good mental health and well-being. But there are barriers to demand for services, as I am sure you all here will recognize how the supply of mental health services is poor. In many areas, we have unavailable services. We don't have any services at all. And what's worse, in many countries of our region, GPs, general practitioners, family physicians, primary health care workers are not allowed to take care of people with mental health conditions. So there is unavailability. Very often is inaccessible. Why? Because it's only in the big cities where poor people cannot go, or they cannot afford to take a day off from work because they have to work very hard, or they probably do not have the money to pay the transport to get to the nearest mental health service, because as you very well know, very often people living with mental health condition fall into poverty. Unaffordable, I just mentioned, and they have low quality. Low quality starting from, for instance, services that are deeply institutionalized and therefore are rejected by the population, because the population wouldn't like to depose their children or their parents to an institution that does nothing but lock people behind locked doors. Another barrier is low mental health literacy. How much does our community know about mental health? What are the myths there? There are a lot of myths. If you get depressed, it's because you're weak. If you get a mental illness, it's because you were smoking too much weed. All those, a pervasive lack of knowledge and understanding, and prevailing beliefs and attitudes. So if you get a mental health condition, it serves you well because you did this and that and that. So there is a lot of those prevailing beliefs and attitudes around people with mental illnesses, that then when the next person is experiencing a mental health challenge, they do not go to seek for services because they might believe that it's their fault, they might believe that they will be judged, and more often than not, this is the case. Am I too fast for the translation? It's okay? Good. Another barrier is stigma that is linked a bit with literacy. What are the stereotype views? We have stereotyped views about mental health. Once mentally ill, always mentally ill. We have a disfatist attitude in the public around mental illnesses. We have fear, shame, and contempt around people that suffer from mental health conditions. These feed human rights violations. Of course, if we believe that it's the fault of someone for contracting schizophrenia or for contracting another mental health condition, then we feel entitled to violate their human rights because we believe it's their fault. They asked for it. This is very often an attitude in the community, in the public, that might not be in this room here, but I'm sure you have heard those attitudes in the communities you live and work with. And last but not least, discrimination and exclusion. And the exclusion is not only by locking people in institution, exclusion is by denying their right to work, by denying their right to education, to some instances by denying their right to property, and to other instances by denying any other rights, such as, for instance, the right to drive a car. There are countries in our region that the moment you get a mental health diagnosis, you are stripped of your driving license, for instance. So therefore, people do not even bother to go and see and check themselves to a doctor of the fear of being stripped of their basic entitlements and rights. And like this was not enough, then we had COVID. And during COVID, we saw how we had an increased, widespread distress. We saw a 28% rise in major depressive disorders, and we saw a 26% rise in anxiety disorders. Globally, 44% of the countries reported disruptions to mental health care in early 2022. So it's as late as 2022. This was not the beginning of COVID, when the societies were shut down. In 2022, nearly half of the countries reported that mental health services were still disrupted. I mentioned the UN Convention for Rights of Persons with Disabilities. This has been ratified this was approved in the United Nations in 2008. It contains 50 articles, and its primary aim is to prevent human rights violations against people on reasons of their living with a disability, including intellectual disabilities and mental health conditions. Therefore, action is needed against stigma, discrimination, and abuse. We need strategies to shift attitudes, to strengthen rights, and to reshape environments. We need environments that are friendly to people with disabilities, including mental illnesses and intellectual disabilities. We need to support people in being autonomous to make decisions for themselves. There is a tool called Quality Rights, and my colleague Olga, who is here, yes, will talk about that later today, so I'm not going to dwell into that. But this is an instrument developed by WHO that aims at building capacity to combat stigma, at creating services on a rights-based approach, at supporting civil society movements, Regina, this is for you, and at reforming laws and policies that I was very happy to be engaged in a discussion yesterday where more than one partner was aware about the need to develop policies in favor of mental health development, mental health services development. And remember, please, that advancing public health is also a key tool to improve mental health and well-being, because good mental health is fundamental to individuals' health and well-being. We have evidence now that that investment in mental health has a great return to society, and we know that comorbidity in mental health is the rule rather than the exception. And therefore, when we look at a person that is living with a mental health condition, we need to be aware about comorbidities, for instance, with other non-communicable diseases, and so on and so forth. And we have, for instance, plenty of evidence to show that during COVID-19, people living with mental health conditions were more prone to infection because infection prevention and control, they were less skilled, or there were no active initiative to support people living with mental health conditions into protecting themselves from COVID, into adopting protective measures. And therefore, comorbidity is, we say, the rule rather than the exception. Now, in order to move ahead the agenda, the mental health agenda, what do we need? We need an expressed interest from the public to support. And in Wrocław, we saw that we had the Institute for Open Dialogue. So I see this as the expressed public interest to support the mental health agenda. Then we have, we need to have an institutional commitment. And we have here leaders. We have here leaders of health services, leaders of the local governments, leaders of educational institutes that very clearly are showing an intent to move ahead policies, plans, and programs. And the presence of yourselves, of a room so rich in representation from the whole country in Poland, shows that there is an interest to move this agenda elsewhere in the country, so to have a national level movement. Last but not least is budgetary. We need sufficient resources allocated for implementation, and we saw how in Wrocław it started by diversifying mental health services. So now from the hospital we also have some services in the community, and there is a very clear plan of multiplying those services in the rest of the city. So not only diversifying mental health services, but also clear plans for expanding community care. So, to go back to the theory, what do we mean by community-based care? What do we need to do? We need to start by deinstitutionalization of care for severe conditions. We need to stop having people with severe mental health conditions staying long-term in any institution, be that a large institution, be that a small institution. An apartment can become an institution. Cases where families that are not supported sufficiently lock their children, their young children suffering from schizophrenia, in an apartment downtown because they don't have any other possibility to support their children. It's a case of institutionalization. So let's think of institutionalization as a process and link it with buildings, because there are buildings who have been institutions 200 years ago and who continue to be institutions now. But let's think of institutionalization as the process that is depriving people from the everyday entitlement, and then therefore their skills, their rights are deprived and are reduced. And in order to do that, we need to scale up community services, and we saw this in Wrocław yesterday. We need, therefore, by doing so, we can reduce admissions. We can reduce admissions when community care goes up, and then we can increase discharges, because we know that if we discharge a person into the community, there will be staff, there will be resources to take care of that person. Then, at the same time, we need to scale up care for common conditions. Are we able to train our GPs so that they can be able to diagnose depression and initiate treatment or follow-up treatment as per a psychiatrist's recommendation? Are we able to prepare, to qualify psychologists that, when placed in schools, are able to work with children and adolescents that are experiencing challenging times? Are we able to support our older people with digital self-help, sending them a message every morning to say, "Good morning, how are you today? Do you need any help?" And then we talk about integrated services into primary health care. I talked about GPs, into general hospitals, and I am aware of the plans in Poland to integrate, to have inpatient wards for psychiatry acute needs in general hospitals across the country, and especially also to talk about the special group, for instance, integrating mental health into care for HIV patients. And we have seen there is enough evidence now that shows that when mental health is integrated into HIV services, then there is a reduced infection. So again, going back to the comorbidities thing, you see, when we work in partnerships, we are able to produce more impact than just the mental health status of the public we serve. We need to work beyond the health sector, because other sectors have a role in complementing healthcare with social services, and I hope next time I come to Wrocław we can see more about how, for instance, social services are working with you into making sure that people enjoy their rights to employment, for instance, or to housing or to education. But it's a process. We understand that it's just the start, but it's key that social services are very well in a very well oiled relationship with you. Now, if you ask me about how we are then reflecting, because I talked about some theoretical concepts, and then I try to link those with what's happening in Poland. But then you can ask me then, what are you doing in Europe? And how we are addressing this in Europe is we have established this coalition. We called it the Pan-European Mental Health Coalition. That is pan-European because it involves EU and non-EU member states, but it also involves policymakers, psychiatrists, all the professions, the mental health professions. It involves employers. It involves, very importantly, people with lived experience, carer organizations, and it's a broad-basis coalition that works for on six priorities. The first priority is to develop mental health leadership. We talked about yesterday and today about leaders. We saw some leaders this morning, and I hope we will be able to see more leadership presented here today. We talk about transforming mental health services, and again in Wrocław we see how mental health services are transformed. And in WHO, when we talk about transformation of mental health services, it's not only about from a big hospital go to smaller houses. It's about having also sufficient staff that is well prepared, that has capacities to take care for people in the community. We talk about, of course, staff in primary healthcare level. We talk about the workforce and so on. The third is integrating mental health into emergency preparedness, response, and recovery. We saw this with COVID, how the increased demand for mental health services was not met. Why? Because the systems were unprepared. And we see it now with the war in Ukraine, how many of the neighboring countries were unprepared to respond to the need of both the host population but also of the refugee population for mental health support and assistance. Therefore, we need to integrate mental health when every government prepares emergency plans, civil emergencies. Then you say the convoy with medical supplies will pass through that bridge and through that other road. Then where is the mental health staff there? So where in the plan is mental health? A fourth package is promotion of mental health in the workplace. And for the sake of time, I'm going very fast. The fifth is mental health and well-being of children, adolescents, and young people, including anti-stigma, suicide prevention, mental health literacy, and quality of care. And the last but not least is mental health and well-being of older adults. Now, the foundation of this coalition is mental health data, because I mentioned at the beginning, 1/3 of our countries are not able to report on data disaggregated by sex. So we need better data, we need more data, we need comparable data. And that's why the foundation for that is mental health data. And with this, I extend a very cordial invitation to join the Pan-European Mental Health Coalition and, of course, to establish a national coalition in Poland. You have here the links that you can follow for learning more about the coalition, but also should you feel inclined to join the coalition, please write to that address and we will respond to you very soon. Thank you very much again for inviting me and looking forward to work together.